Welcome to the early intervention echo session here at the Institute for Disability Research, Policy, and Practice. We are recording today's session. By joining today's session, you are giving permission to be recorded. We use this for educational quality and improvements. We store them on our Canvas page as well as our YouTube channel. So you are always welcome to go back and review these videos and share them with others. It's a great way to just continue to learn. If you're like my brain, it takes me sometimes multiple times to get all the information. Sorry, I don't know why my phone is going off. I thought I had it on. Sorry. If you want to take a minute and rename your profile, turn on your camera, it's just another way that we can get to know each other as we're on this virtual call. We've all been on Zoom for a minute, so should know how to rename our profile, but if not, you can reach out to one of the hub members. They all have an asterisk in front of their name, so they're easier to find via chat. We love interactions and communication during these virtual things. So if you want to ask questions, put in comments, please use the chat button or raise your hand, and we will make sure that those get answered. But as we are discussing things or asking questions, if we use any information, please de-identify that information. Don't use their first, middle, last names. Again, if you have any questions about that, reach out to myself or one of the hub members, and we'll be able to answer that for you. If you've never joined an echo session, welcome to your first one. We will always have what we call our subject matter experts, and we're thrilled today to have the Prader-Willi's clinic with us to talk to us about some of the things that they do. Then we will also have case presentations, and where we have a small breakout room and discuss what our case presenter wants us to discuss. That's a great way to build up that professional networking. To know that when we're out here, we're not just doing our work alone, and we know who to reach out to, all these amazing people on the call. When we are doing those things, whether we're in a large group or in our breakout groups, please remember to just respect the presenter. So use your chat or raise your hand to ask those questions. Keep those brief and on topic. I know sometimes we want to share a story when we're asking a question, but that does kind of derail our presentation. Always introduce yourself and your organization. Again, it just really encourages that professional networking and that building that community. In order to get a credit of attendance, we do ask that you complete the survey. We thank everybody who always completes those surveys for us. It's how we take this information back to our funders to be able to keep these sessions free of charge. So thank you. We also ask that you put in your contact information. And we do that because we want to send you thank you gifts. So we have swag and different things for that. So please take a minute if you want to receive swag and fill in your contact information. Canvas is where we store everything. If you need access to our Canvas page, please just email earlyecho@aggies.usu.edu and we will get you set up on the Canvas page. We also have closed caption available on Zoom. So if you would like to have closed captioning, please turn that on. If you need me to pin or do anything for you, please reach out to me. We love case studies, and I am thrilled today for our case study. Her name is Andy. She is going to be introducing her little girl that she is looking forward to getting all the information from you guys as well. We do have social media, so if you want to take a minute and follow us on social media, that would be great. We share resources, information, and anything else that comes our way. So, like I said, I'm thrilled today to have the Prader-Willi Clinic join us. I am going to stop sharing and turn that over to them. It looks like I need to pin a few people. So, Annabelle, and I saw an ASL interpreter as well. So it might take me a minute to get everybody pinned. Sarah, where is Sarah? But you guys can start talking while I'm pinning everybody. It just takes me a minute.
Okay, well, yeah,
Sorry.
you do your thing. That's great. So I'm Dr. Clements with pediatric endocrinology at Primary Children's Hospital and the University of Utah. I will kind of get us started, and we'll have some slides that I will present, some slides that Annabelle Wilcox, our PA with the Pediatric Genetics Group, and Sarah Roberts, our PWS dietitian, will also share some slides. So we'll kind of bounce around a little bit between the three of us as we present this information. We are going to focus on the early management of Prader-Willi syndrome. So we will not be talking as much around the older childhood or the teenage years or adult aspects of Prader-Willi syndrome. We are going to focus more on infants and the early management. Okay. Annabelle, I think if you're controlling the slides, go ahead. So we have some objectives today. This is going to be part one of a two-part series. The second part on December 3rd will focus a little more on the speech therapy, occupational therapy, and physical therapy, as well as some of the social and family implications and what support is out there. So that's a future echo in about a month. Today is part one. We are going to focus a little more about a case with hypotonia, kind of that early presentation on how an infant might show up. And then we're going to talk about the genetics of Prader-Willi syndrome. It does get very complicated, but Annabelle's going to break it down for us and help us really understand how the genetics of Prader-Willi syndrome occurs. We'll talk about the different clinical characteristics in infants. Again, that's our focus. And we'll talk about the initial treatment goals. And so there are 3 points that we generally push with all families to understand in the beginning. We got to focus on their oxygenation, their nutrition, and get them on growth hormone treatment. So those are kind of the 3 things we really focus on in newborns. Families want to read everything they can learn about this new diagnosis in their infant, but we truly try to focus when they get lost in all of the information. We come back to those 3 pieces, and if they're focused on those 3 pieces, their child's going to do great. Okay, next slide. Again, we've got the 3 of us, Dr. Clements with endocrinology, and we've got Annabelle Wilcox with genetics, and Sarah Roberts, our dietitian. Regarding disclosures, I'm a speaker and a consultant for Clement Therapeutics. They do make a medication for patients with Prader-Willi syndrome, so it's worth mentioning that disclosure. Okay, next. So let's start with a little case. So we've got a little girl who's born at about 39 weeks. She was C-section due to breech presentation, but pregnancy was uncomplicated. All the prenatal care was fine. No real concerns came up. We have a weight and a length there, fairly standard, no specific concerns. APGAR scores are a little bit low at 7 and 8, but not overly concerning. But really what starts to show up is there's a difficulty with feeding. So the latching isn't happening. There's really not much suck. The palate is kind of high inside the mouth, but the baby just doesn't seem interested in feeding and seems very hypotonic. And because of the lack of feeding, had some low blood sugars that had to get taken care of. And so that decreased tone, decreased movement is very striking. For those that have been around newborn babies, when they come out, they scream and cry, and as they're getting wiped off, they're making all the noise that they can. They're fussy and upset, classic baby stuff. And babies with Prader-Willi often are just looking around, not making a lot of noise. So it kind of strikes you as just a little bit different. Okay, next slide. So here's an example of a baby that has this extreme hypotonia, where there's really almost no muscle movement at all. They like to just lay there. So because of that, this baby gets transferred to the neonatal ICU, and some low oxygen, the tone, the feeding. There's clearly some concerns. So what's going on? Obviously, the ICU doctors don't know the answers right at first. So the differential is kind of the term we use, that there's a lot of diagnoses that we don't know which one might be the case. It could be some infection, could be something that happened with the brain. They could have some metabolic disorder, a muscle disorder, brain disorder. There's a variety of things that could be going on, and you just don't know at first. Okay, next. So a couple of things happen for the evaluation. There's an ultrasound of the head to double check if the brain has anything. I don't see anything there. There's an x-ray of the chest, nothing specific. A lot of blood tests get done. Nothing big is showing up on the initial blood test. Here are some comments from one of the providers that when they first saw the baby. So tone and motor activity are decreased. Infant is sluggish and not interested in feeding, which is very unusual for a baby. Wakes up a little bit and goes right back to sleep. So they consult neurology. And of course, neurology says, well, if there's something with the brain, we need an MRI so we can evaluate the brain. And because of some low oxygen, they start the baby on low flow nasal cannula oxygen, just to make sure the baby's getting enough oxygen to the brain while they're working on evaluating what's going on with this child. Okay, next. So of course here, since we kind of know where this is leading, the MRI comes back normal. And so genetics gets involved and they do a telehealth consultation, and they recommend a variety of genetic tests. The whole rapid whole genome sequencing, that's going to look at like all of the DNA, but there's some specialized testing for some disorders that are worth checking for. And so they asked for a methylation test. And while we wait for those to come back, the ICU continues with the baby on NG tube feeds because the baby just is not really interested at all. A sleep study is done. It shows the baby has both obstructive and central sleep apnea. So obstructive, of course, means that there's something that the oxygen and the breathing isn't getting down into the lungs. And central sleep apnea means the brain isn't even signaling to breathe. Sometimes the baby just forgets to breathe. Those muscles of breathing aren't really kicking in like they should. And so the AHI apnea hypopnea index 7.8 events per hour. But I don't, not the pulmonologist, but I think that's a little high. Okay, next. So the rapid whole genome sequencing, because it's rapid, it does come back within a few days. And it does show that there's a deletion on chromosome 15. And so that's a critical region for either Prader-Willi syndrome or another disorder called Angelman syndrome. So knowing there's a deletion in that area, we don't know which one of them this baby might have. But then about 2 weeks later, now the methylation study comes back that can help distinguish between the two. And it comes back saying this baby does have Prader-Willi syndrome because there's the maternal chromosome is there, but the paternal chromosome is missing that critical region. And for those that can have trouble remembering which one's what, I usually think of the paternal chromosome's the problem in Prader-Willi syndrome. And so I think of those three P's. Sometimes people forget, well, is it the mom one or the father one? So paternal chromosome 15, or the paternal chromosome's the problem, then it's Prader-Willi syndrome. That's my way of remembering. All right, next slide. So after about a month, this baby does get discharged home. They now know a little bit about Prader-Willi syndrome. They're reading everything that they can because that's what families do. Baby is on those NG feedings, and because of concern of aspiration, Since the babies are so hypotonic, if they did try to eat and swallow, a lot of it would go right down into the lungs. And so we just say, look, let's just do the NG feeds, stay on some oxygen, and let's get you scheduled in the clinics for some of the specialists that can help take care of the concerns, including the Prader-Willi syndrome multidisciplinary clinic, where we can see a variety of specialists all at the same time. And then we're going to get the family hooked up with the home health. They can get the feeding therapy, the PT, the OT, all of the different therapies that this baby is going to need. And then we discuss things like growth hormone and why is that beneficial. And so we get the baby started on that. And then we generally plan for a repeat swallow study, or ideally a first swallow study about 6 weeks after starting on growth hormone. That growth hormone will help with the muscle strength, which we'll dig into a little bit later. And that helps a lot with the muscle strength. And a sleep study done about 6 months of age. And so those are kind of the discharge criteria. So once a baby is diagnosed with Prader-Willi syndrome, our entire team collapses on the family, providing them with all the information they need, all the therapies they need, getting them all connected with everything that they need so that their baby can thrive. Okay, next.
Right. Thanks, Dr. Clements. So I'm going to talk now about the genetics of Prader-Willi syndrome. So just go through the genetic etiology, and then we'll discuss the clinical presentation, and then dive into those management focuses. So the Prader-Willi syndrome is a constellation of symptoms. It was first described by Swiss physicians Dr. Prader, Dr. Willi, and Dr. Labhart in the 1950s. But it wasn't until the 80s that they identified the underlying genetic etiology. It affects growth, metabolism, appetite, development, cognitive function, and behavior. And it's due to this absence of expression of paternally inherited genes on chromosome 15 in what we call the Prader-Willi critical region. So this is a region of genes that extends from chromosome 15, Q11, to Q13. The combined lack of expression of these genes results in this hypothalamic dysfunction, which underlies the symptoms that we see in the clinical manifestations of the disorder. And there's three possible genetic mechanisms, which we'll discuss in more detail. And these are what we distinguish as the three different subtypes of Prader-Willi syndrome. So there's paternal deletion, as Dr. Clemens mentioned in the case example, maternal disomy, or an imprinting center defect. And I'll discuss each of these a little bit more in a moment. We see it in equal occurrence in both genders and across all races, and the estimated prevalence is about 1 in 10,000 to 1 in 30,000 live births. So this is the region on chromosome 15 that we call the Prader-Willi syndrome or Angelman syndrome critical region. We all have two copies of every chromosome, one that's inherited from our mother and one that's inherited from our father. And this region on chromosome 15 undergoes methylation. So this is a process where certain genes are silenced, depending on whether they're coming from the maternal chromosome or the paternal chromosome. On this region on chromosome 15, these genes in blue are typically expressed from the paternal chromosome and silenced on the maternal copy of the chromosome, whereas the genes in red are coming from the maternal chromosome and silenced on the paternal chromosome. So it's the lack of expression of these genes in blue that are normally paternally expressed that results in Prader-Willi syndrome, or lack of expression or a mutation in the gene in red that results in Angelman syndrome. So this is why it's important to know which chromosome the methylation pattern is abnormal on. So the most common cause is deletion of this region on the paternally inherited chromosome 15. This results in only one copy of these genes coming from the maternal chromosome, which is being silenced, and therefore there's no gene expression. In most cases, this is a random occurrence on the paternal chromosome, but not inherited from the father. There's two common sizes of deletions. So just going back to the last slide, you can see them on the bottom here. There's a type 1 deletion and a type 2 deletion, spanning about between 5 megabase and 6 megabase in size. But there can also be atypical deletions, which either extend beyond these breakpoints and involve more genes, or atypically small deletions, which may have a more mild phenotype. In particular, it's important to know the size of the deletion because if it is larger and extends out to the end of this chromosome involving ChRNA7, this gene on the very end, that has an increased risk of seizures. The second most common cause is uniparental disomy, also known as UPD. This is where the child inherits both maternal copies of chromosome 15, and therefore there's no paternal gene expression in this region. This most commonly occurs when the chromosomes replicate and then fail to separate during egg formation, but can happen via other mechanisms as well. And then third, there can be an imprinting center defect or deletion. So this is the center that's responsible for silencing of the maternal genes and expression of the expression of the paternal genes. And so a defect in that can result in either Prader-Willi syndrome or Angelman syndrome. Rarely, there can be something called an unbalanced translocation, and this is where pieces of the chromosome swap places in a way that causes the genetic material on the paternal chromosome to be missing. This can fall either under the deletion subtype or can result in UPD in the case of what we call a Robertsonian translocation. Um, all right. So oftentimes these infants are being diagnosed in the NICU with sort of red flag history of failure to thrive and difficulty feeding, as we saw in our case study. Oftentimes they're getting a whole genome pretty quickly, but it's that methylation testing that's required to confirm the diagnosis. So this is the gold standard testing, and it identifies maternal-only imprinting in the Prader-Willi critical region. So it differentiates between that Angelman syndrome or Prader-Willi syndrome. In some cases, methylation testing can determine the subtype, especially with this order here that we typically send through ARUP, which uses multiplex ligation-dependent probe amplification. So it can identify deletion and some cases of UPD, but it doesn't give us those breakpoints or that size of the deletion. And so we always follow up with additional genetic testing, such as microarray or whole genome sequencing to understand the size of the deletion or the subtype. Oftentimes, as I mentioned, the whole genome is being ordered on these infants, but we recommend ordering the methylation testing as well. It can take a little bit longer to come back, especially if we're getting rapid whole genome testing, and we need that methylation to confirm the diagnosis. It's also important to know that while there's some described clinical differences between the different subtypes, they're not clinically significant, especially in the infancy stage, and they don't impact our medical management. So it's important to know the sizes of deletions, other genes that might be involved, areas of homozygosity and recurrence risk, but the actual subtype of Prader-Willi syndrome doesn't impact their medical management, especially at this age. All right, transitioning now to talk about some of the clinical features of Prader-Willi syndrome, starting with infancy. It's also important to understand that there is a wide clinical spectrum between these patients. This is across different subtypes and throughout their lifespan. And it can be difficult to predict. We see people with same size deletions that can present very differently. The infancy stage is described as the failure to thrive stage. They have profound hypotonia, excessive sleepiness, minimal crying, suck and feeding difficulties are very prevalent. They tend to have incoordination. They're very high risk for dysphagia and aspiration. Respiratory difficulties are very common as well. They tend to have shallow breathing, CO2 retention, hypoxia, and both obstructive and central sleep apnea. They have hypogonadism, so we tend to see genital hypoplasia, undescended testes in the males. They typically all have some level of developmental delays, and in general, milestones are about twice that of normally developing children, although there can be significant variability in that as well. They have reduced lean muscle mass, so while they are, for the most part, failure to thrive and have pretty low weight, that tissue that they do have tends to be a little bit squishier because of the reduced lean muscle mass ratio. Some of the distinctive facial features that we may see include some narrowing in the temple region, a thin upper lip, downturned corners of the mouth, epicanthal folds, and then in the deletion subtype, we see some hypopigmentation of the hair, eyes, or skin because of one of the genes that's deleted in that region. These clinical features start to transition during childhood, and as they go from childhood and then on to adolescence and into adulthood, the failure to thrive stage transitions into what we call the hunger stage. So the biggest main manifestation that we see is this hyperphagia. Typically begins between ages 2 to 6, although there's definitely variability in that as well. And essentially, this hyperphagia is this significant preoccupation with food, a compulsion to eat, and rapid weight gain can occur if food is not externally controlled. Some individuals will eat non-food items, will dig through the trash for food. So it is this significant preoccupation of food and difficulty reaching satiety. There's intellectual disabilities as well. So testing indicates that most individuals have a mild intellectual disability. Behavioral manifestations become quite prominent, including emotional ability, obsessive compulsive tendencies, psychosis, skin picking. We see incomplete pubertal development and infertility. Short stature is very common. Some other endocrine manifestations that we may see include hypothyroidism, central adrenal insufficiency. They tend to have thickened saliva, so they're more prone to cavities. Strabismus is common. Scoliosis is very common and often requires bracing or surgery. These individuals also have pain insensitivity and delayed gastric emptying. And it's this combination of the hyperphagia, the developmental delay, the pain insensitivity, and the delayed gastric emptying that puts them at really high risk for gastric rupture. So in addition to wanting to manage the obesity and the secondary medical complications from that, food security is essential to preventing the serious and life-threatening medical consequences. So if you have a patient that you suspect Prader-Willi syndrome in, you can always consult our genetics team here at the University of Utah. We're happy to see the patient in clinic and evaluate or an inpatient consultation. But if genetic testing is being ordered, we recommend getting that DNA methylation first, and then either concurrently or follow up with additional genetic testing. But that methylation is needed to confirm the diagnosis. So early diagnosis gives the parents the opportunity to begin appropriate interventions and therapies as soon as possible. This includes nutritional guidance, growth hormone treatments, oxygenation, and initiation of early intervention therapies. But it also allows for the families to establish support systems, including with other families or a parent support group. And together, this all contributes to improved quality of life for these individuals and their families and best outcomes. So a new diagnosis is very overwhelming for these families, and there's a lot to consider how it's going to impact their immediate lives as well as their future lives. And so we like to focus the early medical management on three key pieces that are essential for the best outcomes for these individuals, as Dr. Clements had mentioned earlier. So this includes appropriate oxygenation, nutrition, and growth hormone therapy. And so we'll go through these three in more detail. Okay, so starting with oxygenation, and this is primarily managed by our pulmonology team. But infants with Prader-Willi syndrome exhibit pulmonary abnormalities, including central sleep apnea, obstructive sleep apnea, hypoventilation, which results in hypoxemia and hypercapnia. And this all kind of comes from this combined effect of the hypotonia, the low tone, as well as an impaired central respiratory control. Central sleep apnea is especially prevalent in the younger infants, and some studies have shown up to half of infants with Prader-Willi syndrome have severe central sleep apnea. This is all further exacerbated by being at a higher altitude here in Utah. And so because of this, we recommend that all of our infants diagnosed with Prader-Willi syndrome go home on oxygen. They then will have outpatient pulmonology follow-up. They typically do a sleep study closer to 6 months of age, which has often allowed the infant some time on growth hormone and appropriate nutrition and increased sort of wakefulness periods. And then that repeat sleep study will guide oxygen needs going forward. The central sleep apnea tends to improve with age, but some infants do have persistent abnormalities on the sleep study, and some children later will develop obstructive sleep apnea, which is often related to both evolving obesity as well as their continued low tone. All right, I'm going to pass it on to Sarah now to talk about nutrition.
All right, well, we've heard a lot about hypotonia, so now we're going to hear a lot about feeding tubes because you need those when you have hypotonia. So, infants with Prader-Willi syndrome usually require a feeding tube for kind of these main reasons. So, again, weakness due to hypotonia, which means low muscle tone, insufficient head and trunk support or control, and then oral motor weakness. And those last two are also related to the hypotonia. So these things impact their ability to consume substantial amounts or adequate amounts of breast milk or formula or just overall nutrition for appropriate growth and development. So these feeding tubes are necessary until they develop the needed strength to feed on their own. So these patients, when they're first identified, need to remain NPO or just nothing by mouth until they're cleared with a swallow study. And as a general rule, we do this about 6 weeks after starting growth hormone therapy, and we'll get into that more for sure. But we pretty much expect that all of these babies will aspirate because their tone is just so low. So if we do a swallow study before the growth hormone, they're very likely to fail. And if we do it too early, we're kind of not setting them up for success. We're setting them up to fail. Because if they are aspirating, they're going to get very conservative recommendations, nothing NPO, we're not going to work on anything. And then you have to wait much longer than to get the next swallow study. So it's better if we just wait till we're on growth hormone. We see that that really improves their strength and their ability to swallow, and they're much more likely to do better on the swallow study when we do it. Next slide, please. So some of the things that feeding tubes are helpful for, we are reducing the risk for aspiration, which is when liquid goes into the lungs. Aspiration, of course, can cause respiratory illnesses such as pneumonia, which we all know is very bad. We have had a couple of patients develop pneumonia or go into the hospital with upper respiratory illnesses, which did seem to be related to some oral feeding done a little bit too early. So definitely a concern there. It allows us to keep the infant safe and hydrated. So in addition to just like gaining weight and growing appropriately, getting nutrition, we also need to make sure they're not becoming dehydrated from not being able to take liquid nutrition orally. It allows the infant to receive, again, the needed fluid and just nutrition that they need, and allows the promotion of safe oral intake. So we do want to promote oral intake as they're ready for it, but we're going very slowly. We want the speech language pathologists and the occupational therapists really involved and working on those oral skills and trying to build up their strength. But because we have to go so slow, we need those feeding tubes to allow us to grow normally, and we're not trying to push things too fast and put them at risk for that aspiration. One distinctive factor in Prader-Willi syndrome is that tube feedings do not inhibit oral feedings or cause oral aversion. This is a concern in some non-Prader-Willi babies. If you leave them on a tube for too long, they're like, I don't have to work to eat, and if you make me, that's just too much work, so I'm just not going to do it. And they just don't eat, even if they were physically ready to. That does not happen in Prader-Willi syndrome, so we don't have to worry about that in these guys. Next slide. So some good news and bad news with the feeding tubes. The bad news is that nearly all newborns with Prader-Willi syndrome will have this severe dysphagia and need the feeding tube. Most children will require the NG tube for the first months of life to maintain nutrition. It is a spectrum disorder, so we have had a couple of patients who presented or were picked up later in life, like when they were toddlers or even into their teen years. So there are a small handful of patients who might not present like this in infancy and can take things orally, and they wouldn't need a tube, but the vast majority will. G-tube placement, and this is really important, G-tube placement is not recommended due to the risk of stomach rupture. So Annabelle was just talking about how, they have delayed gastric emptying, and when they're older, they have these very large binge eating episodes if they're not being monitored appropriately. And if that happens and the stomach wall is already weakened from a G tube, it's just increasing their risk for rupture. And it is a significant mortality risk. So we try to avoid that at all costs or as much as we can. We have had a couple of patients who did need a G tube because no matter what we tried, they kept pulling the NG. But again, it's something that is really kind of a last resort. The good news is that the swallowing problems really improve over the first 2 years of life. These kids are getting lots of therapies very frequently, and the growth hormone really helps with that as well. So after a while, things do get better. Most of these kids are oral feeders or getting 100% of their nutrition by their first birthday, but it can be, from 6 to 10 months that they're on the tube or up to like a year or even close to 2 years, but we do what we can to try to minimize that. And then again, the oral aversion is not a concern in Prader-Willi, so that's working in our favor. Next slide. So this next information is kind of more like what the speech language pathologist and the occupational therapist would be working on. But if we're seeing that the infant presents with a weak or completely absent suck, then we want to work on overall physical strength and stimulation of mature sucking bursts. So we don't want them practicing feeding beyond just the pacifier or finger dipped into milk or formula. And that is something that should be driven by the speech therapist. We, again, don't recommend getting an early swallow study for newborns with a very poor suck because we just know that they are all going to aspirate, so let's not put them at risk. NG feedings are appropriate at this stage, as we've been talking about. Most infants show improvement in sucking and swallowing about 6 weeks after the growth hormone therapy, like we talked about in the first slide. So this would be an appropriate time to do that swallow study because their muscles and their tone are doing better, and we see that they do much better on the swallow studies at that point. If a functional suck is not present by 6 months of age, then we would consider trials with an open cup. And again, all of this is hopefully being driven by the therapists that are watching them very closely and giving them orals, like exercises to work on over time. And this isn't on the slide, but just kind of the last thing I wanted to mention from a nutrition standpoint at this stage is that watching growth frequently is very important. So I'm usually trying to get growth measurements every other week. Their needs can look a little bit different from a typical infant, so it's important that they have somebody, a dietitian, watching their growth and adjusting their feeds with them. And that can be done by early intervention therapists sometimes or the outpatient therapists, but sometimes we rely on the primary care providers or the pediatrician. So if any of you are listening, just know it's really helpful if the patient lives nearby. It's very useful for them to come in and get measured in the clinic whenever possible.
All right, we've talked a little bit about the oxygen to the brain and the importance of nutrition via the NG tube. And then the third point that is what we typically focus on for families is the introduction of growth hormone treatment. As of right now, it's really the only medical intervention or really, I guess, medication that we can use that has a big impact in kids at this age. It's one of the biggest advancements that we have seen in the last 50 years. And so almost all babies go on growth hormone at some point. Some institutions wait till babies are 1 or 2 years old. We are big proponents here in Utah of getting them started much earlier. We are trying to get kids on growth hormone by the time they're about 2 to 3 months old. So we're big believers. We're among the early adopters in the country as far as getting kids on this very early. And so why growth hormone? Well, we do know that the kids with Prader-Willi syndrome are short, and adults with Prader-Willi syndrome who never got growth hormone are very, very short. But really the big benefit of growth hormone is the muscle development. And so we often explain to families the reason NFL football players and bodybuilders use growth hormone illegally is because it builds muscle. It is very, very good at building muscle. And so in these kids who have very high fat mass and very low lean muscle mass, if we can get their muscle mass and muscle strength to improve, that will help them in pretty much every aspect of their life. This will help with the breathing and the oxygenation. If their breathing muscles are stronger, they will breathe better, get oxygen to their brain better. And then the muscles of the mouth for sucking, for swallowing, for coughing. If the formula starts going down into the lungs. So all of that muscle needs to be stronger so that these kids can develop better. So the muscle development is big, and then it brings down that body fat a little bit. We will never be able to get those back to normal, but we want to try to restore a little bit of that balance if we can. So that improves body composition as well. It's important for bone mineral density, and then it'll help them walk sooner. Without growth hormone, I believe the average age of walking is around age 4 or 5 years. With growth hormone, we can often get them starting walking by about age 2. Occasionally, it's a little before 2, but it's often 2 or later. And so with growth hormone, they can now start to move around. And so there are some newer studies that seem to show growth hormone helps with cognitive function, brain development. And we often explain that the growth hormone is not acting in the brain, at least not that we're aware of. The growth hormone is allowing this child to now fight gravity. One of the things we often joke about is gravity is very hard to overcome. These babies just lay there all the time. They don't want to raise their arms. They don't want to put their hand in their mouth. They don't want to kick their legs. They don't want to, when you try to stand them up, their legs will just squish. They don't want to do any of that. Gravity is hard. And so when you give them growth hormone, their muscles get stronger. They can now fight gravity a little better. Now they can take a rattle and shake it. Now they can grab some Cheerios and put it in their mouth. Now they can start crawling, eventually start walking. And now this child that was just laying there doing nothing, getting zero brain development, now gets to interact with their environment, gets to hold and touch and push and feel and crawl and explore. And so all of those things will help the brain develop. But if they don't have growth hormone, they're just going to lay there. Their eyes will be looking around, but they're going to be more tired. They're going to sleep all the time. They just don't have the energy or the muscle strength to do normal baby things. And so in the introduction of growth hormone, it helps in so many ways that we are big believers in getting them started early. Okay, next slide. So again, I think this one's a little more straightforward. It's something we kind of talked about. By 2 to 3 months old, we want them on growth hormone. Does it help them grow? Yeah, it does. Are they still going to be short as adults? Yeah, we're not going to fix that. But they are going to grow better by being on growth hormone. Some of the downsides, well, it's a daily shot. Every day, every day, every day, until they're 15 years old, 20 years old. My hope is even as adults, they can stay on growth hormone for the benefit of the muscle strength. So that's a lot of shots over the years. And a lot of families get nervous about giving this newborn 2 or 3 month old injections every single day. But once they've done it, and about a week or 2 into the growth hormone, families start to see a difference. The baby that wasn't hardly doing anything is now starting to wiggle and move, starting to be awake longer. Many, many things start to kick in. It doesn't happen after the first injection, but usually within a few weeks, we start seeing that difference. And then that's why after about 6 weeks, now let's think about doing a swallow study. Let's see if we can start letting the baby feed, if they will protect their airway now that their muscle strength is better. Some people ask about the different brands of growth hormone. There's about 8 brands of growth hormone. They all work equally. There's not one that's better than the other. There are growth hormone companies that have produced weekly growth hormone injections. So that's only once a week, which would be much nicer than every day. However, those have not been studied yet in Prader-Willi syndrome specifically. So we are hopeful that some of those companies will start studying it so that in the next couple of years, we can start introducing weekly injections instead of every single day. But as I mentioned, lifelong therapy is the goal. We don't expect them to just stop it after a year, stop it when they're done growing when they're 15 or 16 years old. I expect that if they will get benefit if they stay on it even as adults. Okay, next. Okay, I think Annabelle, I think you can take over. I can't remember if I was going to do this one or you were going to. I guess I'll take this one. Then I think the next one is for you. So we do believe in a multidisciplinary approach, right? And this is a lot of providers. This probably isn't even all of the types of providers that these babies are going to need to see. Some will need to see these right away, early on. Some of these may be more of an issue as they get older. But there are a lot of professional providers, both at the medical clinic hospital side of things and at the therapy level, coming to people's homes, doing all those different therapies that these babies need. There are a lot of people that need to get involved, and that can seem overwhelming. So we are very happy to have a Prader-Willi syndrome multidisciplinary clinic. It does not have all of these providers, but we generally get 8 to 9 of these specialists all together so that these families can see us all at one time on one day. And we try to do that about once a year for these families. So just a lot of medical folks. One of the most interesting things that I find, many genetic disorders have cardiac issues. You'll notice that's one of the few specialists they don't have to see. Very few of our Prader-Willi kids have a cardiac issue. Does it exist? Yes. But that's interesting to me as a medical provider that's one of the few specialists they don't have to see. So we're fortunate there. All right. I think that's what I had. Annabelle, if you had anything else on that one, or you can kind of take more of this slide.
Yeah, I could talk a little bit more about our clinic. So as Dr. Clements mentioned, we have a multidisciplinary Prader-Willi clinic here through the University of Utah. The providers in that clinic are genetics. We have Sarah, who's our dietitian through genetics, Dr. Clements with endocrinology. We also have psychiatry, psychology, speech therapy, occupational therapy, and physical therapy. So all these providers come to each clinic and see each of these children once a year. Here are some of those medical contacts on here if there's questions or concerns for some of the particular medical providers. We'll be joined next month by our therapists. So our speech therapist, occupational, and physical therapist will all be joining to discuss some of the therapy goals of Prader-Willi syndrome. So we'll have their information as well. But I think the one specialty that all of these children have to follow that's not on this list is pulmonology. So just important to note. There's other specialists as well that Dr. Clements had mentioned, but pulmonology is the main one that they all need to follow with, that is not part of our multidisciplinary clinic. So if there's a child who has Prader-Willi syndrome that's not part of our clinic that would benefit from being seen, or if you have a patient that is part of our clinic and there's medical questions, you're welcome to reach out to me. My contact information is on this slide. Right now, our clinic is housed through genetics. So a lot of those questions, concerns, and new referrals will come through us at first, and then sort of triage them on to the providers as needed throughout the clinic as well. And then for emergency needs, there is a PWSA 24/7 emergency medical crisis hotline. So this is through one of the support organizations, the National Support Organization, that has someone 24/7 available for medical emergencies. So this can be a really helpful number for families to have if there's questions. We still recommend that they reach out to us to let us know if they're being hospitalized or if there's a medical emergency going on as well.
I could add one more piece kind of around that. We're very fortunate here in Utah that we have a very active family organization. So there's a Utah PWSA organization that most of the families participate in. There are all kinds of get-togethers that they do, fundraisers, fun walks. But the family organization, because we have somewhere between probably 60 and 80 kids and adults with Prader-Willi syndrome here in Utah. I think there was an estimate of 120 at one point if you included the adults. In the pediatric clinic, I think we managed somewhere between 50 and 60. So that's not an outrageous number. And so these families get to know each other very well. The family organization help and support each other. When a baby is born and the families don't know anything and they're trying to figure out what do I do, the family organization provides a lot of support for these families and helping make sure that they get to their doctor appointments and have what they need in their homes. And so we have both the medical side and a lot of the therapies all kind of housed in what we've kind of discussed today. But the family organization, I don't want to forget about how important that organization is for all of these families. I think if you had hundreds and hundreds of families, it'd be hard to keep that together. But the fact that there's a small enough number that these families get together, we're very fortunate that they're very, very helpful for both the families and then getting them the medical care that they need as well.
Thank you. Yeah, so all of these patients, as soon as they're diagnosed, we connect them with the family group. And so they're, for the most part, pretty well connected. Here's the information for their website as well. So upwsa.org, and their contact information will be on that website to reach out if there's a family that you think would benefit from being connected, or if there are other questions or concerns. And we'll also have them be joining us at the presentation next month as well. So they'll be able to discuss more of what they do outside of the medical management that we discussed today. This is also a great textbook for the medical professionals on the call. It has a lot of great information about Prader-Willi syndrome. We have access to it through our clinic, so if there's ever questions, I'm happy to share that as well.
Right. You do have 3 questions. Do you want me to interrupt before you move on to your next slide?
Yes, that'd be great.
I think that was the last slide. I think we completed the didactic portion of this. So I think at this point, I would say, yeah, I would welcome some questions. If people have a question, please put it in the chat. If we need clarification, we can ask you a little bit to clarify what the question means, but we'll start attacking some of the questions that have come up so far.
All right. So Pat Boyle is asking, once they're eating well, what nutrition do you focus on? Low carb, high protein?
Yeah, so once they are actually eating foods and we're sort of out of the infant stage, there's lots of different ways to approach the Prader-Willi diet, and I've seen lots of families do it a little bit differently, and sometimes that's working for them, sometimes it's not. So I do take an individualized approach. In general, we are focusing on maybe a little bit higher protein than kind of standard, like a little bit higher than the RDA. We want to focus on lean sources of protein instead of very high fat sources of protein. We want whole grains in there, vegetables, small amounts of fruit, and healthy fat. It looks a lot like a typical of what you might think of a healthy diet, and I, hesitate to say that word, but you all know kind of what I mean. But just the portions are scaled way, way down. And again, I have some families who do much lower carb, and sometimes the weight is controlled really well. Sometimes it's not. I have some families who are focusing on doing higher fat because theoretically that can help the individual feel more satiated. Sometimes it works, sometimes it doesn't. So definitely individualized, but focusing on fiber and lean proteins and all those good things.
Great, thank you. The other question is coming from Heather Waters. She's asking, can you talk a little bit more about obstructive versus central sleep apnea?
Yeah, I can take that question. So we see both of them in Prader-Willi syndrome. In the infants, we tend to see more central sleep apnea, but also can see obstructive sleep apnea. Obstructive sleep apnea is coming more from when the upper airway muscles relax during sleep, and so there's not enough oxygenation that's going into the lungs coming from the airway itself. Where central sleep apnea is coming from the signals from the brain actually not telling the respiratory muscles to breathe properly and allow enough oxygen to come in. So central is coming more from the brain. Obstructive is more coming from the airway. And we see more obstructive sleep apnea in our older children, especially with the obesity. And so it tends to go from more of a central sleep apnea picture to obstructive sleep apnea picture as they get older.
And there's not a whole lot you can do for central sleep apnea, right? The, there's not really much. Obstructive, if they have large tonsils, large adenoids, they'll see an ENT provider, might consider getting their tonsils and adenoids out. So there are some things you can do for obstructive, uh, but there's not as much for the central. But many of the kids are on CPAP while they're sleeping to help ensure that the air is getting in and the oxygen is getting to the brain.
Great. The next question is from Andrea, and she's saying, are the majority of children with PWS diagnosed early?
Now, yes, a majority of these children are being diagnosed early. There's still exceptions of some infants that are maybe being diagnosed a little bit early, or sorry, a little bit later in infancy, but in general, majority now are being diagnosed early in childhood. Historically, that wasn't always the case. But I think now that we have greater awareness and more accessibility to genetic testing, most of these infants are getting diagnosed fairly quickly. We still get quite a lot of referrals to our genetics clinic for older children or adolescents with obesity and concern for Prader-Willi syndrome. But one of the key pieces that we think about if this could be Prader-Willi syndrome was if there was that period of failure to thrive, difficulty feeding early in life. Without that, it's pretty atypical to be a case of Prader-Willi syndrome.
Yeah, I would agree with that as well. A lot of patients who are now just struggling with obesity and weight concerns, they were also very large as a 1 and a 2-year-old, and they've just always been interested in food. And so providers might think, oh, this baby's always been interested in food their whole life. That's Prader-Willi syndrome. And actually, it's the opposite. Prader-Willi babies have zero interest in food. They need tube feeds. Their failure to thrive until they get to around age 3 to 4. I think Annabelle had said 2 to 6. It generally is 3 or 4, but there's a wide range as it is a spectrum disorder. But I think most of the babies in the last 2 or 3 years, they're getting diagnosed while they're still like 3 weeks old in the NICU, maybe 2 weeks old, depending on how fast the genetic testing comes back. I think in the past, it was more likely that they would make it out eventually and make it till 2 or 6 years old before they're diagnosed, but we just don't see that as much anymore. The hard part is you don't know who you've missed, right? We think we're catching them all now, but it certainly is possible that there are some patients who are very mild on the spectrum that got missed and may not get diagnosed until older in childhood. But pretty much every new diagnosis that we've had in the last couple of years, they've always been about 3 or 4 weeks old. So we're catching them quite early. I think that's a lot of benefit to the genetics team and the family organization for getting the word out, making sure that the neonatal ICU providers are aware of this. When they call, they're being encouraged to do the right tests. It used to be that they'd get calls and like, oh, we didn't do the right test. But nowadays, I'm getting the sense that when the ICU calls genetics, the right tests are already pending. Sometimes they call before they've sent anything, but it does seem like the word has gotten out to be testing for the correct things. And so we are seeing that age of diagnosis is actually very, very young now when it didn't used to be the case. It does help that the genetic testing is much more rapid, more accessible, not as expensive. That has made a huge difference in both Prader-Willi syndrome and then a lot of other genetic disorders as well.
So I have a follow-up to my question. Is there like a screening tool or anything for this to kind of give us some red flags, like, an MCHAT, or we do the Hein in Idaho sometimes. So just to kind of get us on the right track, or is that just not needed because it's being caught so early?
That's a good question. There's not one that I'm aware of, but I'd say in general, it's not needed because it's being caught so early in these infants that have this profound hypotonia and difficulty feeding. So I think at that age, those are really the main features that we're seeing that suggest the diagnosis.
Yeah, I mean, I think we still see a lot of people who are very overweight. They want food all the time. People are worried about Prader-Willi syndrome. And so it's appropriate to refer to genetics if you think there's really a chance. But almost all of the cases of that are kids who are large at 1 year, 2 years, 3 years, and that's not going to be Prader-Willi. So I think that if you just had to pick two things, it's that extreme underweight, feeding issues as an infant, and then can the obesity come later in life. So they really have to have both of those, or it's not going to be Prader-Willi syndrome.
Great. Well, thank you. It does not look like there's any other questions, but I'm going to give it 1 minute. See if anybody has anything. If not, I will ask Andy to speak, and she is our case presenter, and I'm really excited to have her hear everybody's wonderful ideas. While I'm giving it a minute, I'm going to ask the ASL interpreter, who are you here for? So I make sure you're get put in the right room. Is it Lauren Ortiz? Okay, thank you.
No.
Marilyn. Okay, thank you. All right. Thank you for this wonderful information. We'll look forward to next month. Andy, if you will talk, I will highlight you and you get to share your cute little one. And Andy, if you are talking, you're on mute and I haven't seen you yet.
It looks like her screen is black, so she might just be having some technical difficulties.
There she is. Okay. And Andy, I don't know if you want to come off mute.
Oh
So
no,
Tori,
we're super excited to see your daughter.
oh, she was super excited to be able to share this.
Yeah.
Okay, well, I do have her questions. So, Andy, if you can come off mute, I'll let you talk. If not, I'm going to go over her questions. So, her cute little one is followed by the Prader-Willi's clinic and has just wonderful things to say about all of you guys. What she is really wondering about is that with this holiday season quickly approaching, how do we work on educating the extended family about her syndrome and avoid tantrums related to food? She's really wondering about how do we have a healthy relationship with food, given that their entire family has had to shift their focus regarding eating. And if her big kids want a snack or treat, they often have to eat it in their room away from Ava. And then while she looks really normal, and her disabilities will become more apparent as she gets older, right now it's difficult to explain to family why her diet is so restrictive and she's so obsessed with food. So how does she explain it to other parents, families, and friends that they come in contact with her? So we're going to go ahead and move into breakout groups. Heather.
It looks like Andy is here. I can see her.
I can't see her yet. So thank you.
I'm
Andy.
so sorry. I'm on my computer and it just froze as soon as I tried to unmute myself.
There you go. So, okay.
Yeah. Thanks for letting me come and chat about Ava. Ava is my 2.5-year-old daughter with PWS. And as I was listening to the presentation by Dr. Clement and Sarah and Annabelle, who Ava sees at the clinic and in practice, every single thing that they said was exactly how it played out with Ava. So yeah, she hasn't started hyperphagia yet, which is the food seeking, but all of the other symptoms we we are seeing in Ava. And then, Janelle, did you pose the questions?
I did pose the questions. I don't know if you want to give
Okay.
any background about your cute little one that will help with those questions.
Yeah. Did you go through all three of them or just the one?
I went through all three of them. I kind of summarized them,
Okay.
and then we'll go into breakout groups. I will move you in between the breakout groups. So if there's clarifying questions, they'll be able to answer those for you.
Can you show us
Perfect.
Ava? Is she there right now before you switch to the breakout? We all want to see Ava.
Can I share my screen?
You certainly can.
Okay, give me 1 second and I will show you a picture of Ava. She's the cutest. I'm not biased, but she is pretty dang cute.
We're all waiting with anticipation. Adorable, Andy.
So this is Ava at Halloween. Halloween is a really tricky, well, I think just in general, the holidays are really tricky for PWS individuals. And even at this age, it's tricky for Ava because she sees her siblings getting lots of candy and us giving out candy, and she does not do well with that. So it's interesting because I say that even though she doesn't have hyperphagia, she is obsessed with food. So she is very concerned about what we're cooking and what we're eating. And if other people are eating and she is not, she loses her mind. And all of her play is food related play. And yeah, so I think my questions are in regards to the holidays and just how do we navigate that with family members that even though they're aware of the syndrome, we don't want their experience with Thanksgiving and Christmas to be limited because of Ava, but we also are trying to minimize her freakouts. And then also her siblings, because siblings can't eat food around her. We don't have treats in the house anymore. How do I make sure that my big kids don't develop unhealthy relationships with food?
Okay. And like I said, Andy, we will be moving you between the breakout groups. So if you have clarifying questions or you want to ask Andy another question in your breakout group, she'll be joining there. So again, Heather and Kristen, you guys are going to tackle that question number 1. Kate and Pat, you're tackling question number 2. And then Rebecca and Leo, you're tackling question number 3. And hopefully, if I've not put the ASL and person in the same group, please just chat me and I will move that.
Can you reiterate the questions for those of us that are slow?
So, Pat, you should have gotten a chat on that. You are taking question number 2.
So I have to get into the chat before it disappears.
Do you see it?
Pat, I'm taking a picture. I'll be in your group with you.
There you go. Great. All right. Kate, Tori, if you want to go ahead and move everybody into breakout groups. All right. So it does sound like we have everybody back. I know that we are short on time, so we may not be able to go over everybody's, but Pat, what is one idea from your breakout group? Or Kate, who took notes?
Oh, I'm gonna bravo Kate. She said that the Daniel Tiger has a peach allergy video that he says you can eat peaches, but I can't. And then somebody else mentioned, wasn't it an allergy book for toddlers to just discuss it?
Oh, that's a great one. Okay, Rebecca or Leo. I don't know who took notes.
Me, I took notes.
What's
One
one
of
idea?
the really good ideas that we had was to make a little short explanation video, just kind of explaining the key points behind Ava's diagnosis, which would make it easier for the parents to go out during meal times, especially when they don't want to go through the hassle of having to explain it over and over again. They can show the person the video and be like, hey, and it sets that boundary as well. So.
Great. And then Heather or Kirsten, who took notes in your group?
Yeah, I take notes. So one of the things we were talking about, because it was the question that had to do with the holidays, is trying to come up with some new traditions that perhaps are not built around food, but are still really fun even for the kids.
Awesome. Andy, what we will do is so the note takers send that into our early echo at aggies.usu.edu, and we will compile all of those recommendations and shoot those out to you after we compile them. They are also on our Canvas page, so if anybody else on the call wants to see all the recommendations for a family that you work with, and take those ideas, that will be out in the next week or two. So Andy, I'll get those to you. And then,
Thank you so much. I'm so excited. Thank you.
yes, thank you. And thank you to the Prader-Willi's Clinic for presenting for us, and looking forward to next month on, it pains me to say this month out loud, December 3rd. I cannot believe it's happening. So thank you all. Have a great rest of your day, and we'll see you next month.